can show you my brother.
All right.
Oh. Okay. So can you start off and tell us, so you're a licensed clinical psychologist, you're a PhD, but you went to undergraduate and you're an economics major, right?
That's right.
So tell us the journey to psychology.
Yeah, so this is sort of a long story, but I'll try to make it quicker. Yeah, so in college, I really liked psychology. I remember reflecting on this after I pursued a graduate school in psychology, like, how did I get here? And I went back and I actually looked at my college application to see what I, at that time, had communicated I was interested in. And on my application, I wrote psychology and mathematics. And so in college, I really loved math. I actually always loved math and tended to excel at math. And it just got kind of hard at a certain point. And I was at a liberal arts college and I thought, there's no sort of business major. Economics might be the best route for me to go with sort of my math interest in sort of a social science direction. And so I ultimately majored in economics, having, again, taken several psychology courses and always liking it. And ultimately, I went to selling life insurance first. You might be a policy holder, Uncle Tom.
That term policy expires next year.
Oh,
I've
okay.
done the whole route.
Yeah.
Covered me well.
Yep. And so I did that. I had an internship and I stuck with it for a little while. And I liked interacting with people. That's what I learned. I liked communicating with people and talking with people and wanting to try to help them in some way. And I found myself trying to carve out a niche within life insurance around estate planning for individuals who had children who would be dependents for the rest of their life. So had some sort of special needs. And then ultimately decided that wasn't the best fit for me and transitioned to a public transit consulting firm in New York City. So I thought I wanted to maybe go into kind of housing within economics or public housing eventually. And again, trying to kind of think about like, how can I twist this economics degree into sort of how can I make a difference? How can I help in some way in public service maybe? And that's when I was living in New York City and I loved it. It afforded me this opportunity to live there. And I just found myself thinking, I don't love what I do and I want to love what I do. And it got me back to thinking about psychology. And so I took some courses in psychology while I was working and then ultimately made the decision to pursue a job in research. So what I did was actually, let me back up a second. When I was working at the public transit consulting firm, I actually bid on a proposal, right? So this consulting firm, we would kind of have requests for proposals like grants and if we won the grant, then we were the consulting firm that would work on the project. And there was one project on rail related suicide that interested me. And I kept finding myself interested. And again, I'm like more interested in this side of things. And so we actually submitted that grant and got it. And that was at the time where I was also pursuing, a class in psychology. And it kind of culminated into thinking, I think I want to make this transition in my career. And I think I was 23 at the time and thinking like, oh gosh, how am I going to do this? Like I've made my bed and I need to stick with this career at 23 and thinking it was so hard to make that leap then.
Meg, so the classes you took, you're unmatriculated. You were just taking graduate level classes or undergraduate or what was it?
I took undergraduate level classes while I was after college. Yeah. So I took a statistics class. I had taken what was kind of the equivalent to that in economics, but I needed statistics and I needed research methods. I knew I would need that. I had taken abnormal psychology, personality psychology, social psychology in college. Okay. I also had contacted the career development department of my undergrad to talk to alumni who were psychologists or who were social workers or licensed therapists, about different avenues that one can take to pursue and, to be a therapist, to figure out, do I want to be a social worker? Do I want to get a PhD? Do I want to pursue a PsyD? What route do I want to take potentially? And that's how I kind of determined the next step for me. If I wanted to get a PhD, was what I kept hearing was I needed more research experience, that for that degree, you're going to need more research experience, rather than a post-bac program in clinical psychology, or rather than necessarily more clinical experience. So that was my first step. And I applied to Massachusetts General Hospital in Boston to be a research assistant on a project studying pediatric bipolar disorder. And I got it. I got that job. And that's when I moved to Boston. And that sort of started me on kind of the more linear psychology path.
I don't remember that. So what did you do there as a research assistant? What was that like?
Yeah, so there I was a research coordinator. So I was, there was a study looking at, it's a genetic study on pediatric bipolar disorder. So I recruited families with children who had emotion dysregulation, or had a diagnosis of pediatric bipolar disorder. And they were, the study was looking at essentially if there were genetic links to the disorder. So they would take, saliva samples of the parents and the children or the child, and do different kind of diagnostic interviews. So structured interviews on the parents and the children around whether, what their diagnoses were. As the coordinator, I was doing more of the recruiting and coordination of scheduling the study participants. But I was also trained in administering, intelligence tests too. So I would, in that job, I learned how to administer different tests for cognitive abilities that I would do, for the participants who would come in for the studies. And I did that for 2 years.
Now, Meg, your goal was to be a psychologist, and I'm thinking to be on the clinical end, but you did all this stuff because this was the requirement to get to be a PhD. So you had the foresight to look into, well, I got to do research, I got to do stats, even if that's not your jam, because that served the goal. Is that correct?
Well, I'd say it's sort of correct, because I think originally I was the clinical work was appealing, but what was also appealing about the PhD was the flexibility in what you could do. So you could be a researcher, and I always love math, and there's a lot of statistics in being a researcher, and that came naturally to me, and I thought that was unique. A lot of people who are clinicians don't also, I find, are not also the people who also want to be running statistical applications and, doing the methods parts of research projects. And so I thought that's just sort of a unique fit for me, where I love the clinical work, but I also really like exercising this part of my brain. And I can kind of figure it out as I go. So if I end up wanting to do more research, this degree will allow me to do that. If I want to do more clinical work, this degree will allow me to do that. Or if I want to teach, I can do that as well.
Okay. So what comes after that? The research.
So after that, so I applied to graduate school. People usually do like a 2-year stint in these research positions. And so after year 1, they'll apply to graduate school, and then go, finish their next year of the research job, and then they go to graduate school. So I did that, and I didn't get into graduate school the first time. So I applied to like 20 schools. I got 1 interview, and I didn't get into that school.
Wow.
And so that was a bit disheartening, but it was also, humbling and helpful to test you about whether you really want to do this. And it was possible I could have stayed at Mass General to do another year there, but I thought, I didn't get into grad school. Maybe I need to kind of change up what I do to improve my application. And so I looked for other jobs and I applied to McLean Hospital, which is a psychiatric hospital outside of Boston. I got a job there where I was working in what's called the behavioral health partial program. So partial programs, you may know this, are kind of a partial program at a psychiatric hospital is a more intensive level of care than outpatient level of care, but it's not residential or inpatient. So
Sure.
residential is you stay overnight, but safety isn't a concern. Inpatient safety is the main concern. It's usually a locked unit, or it is a locked unit. A partial program is when someone isn't making gains from outpatient therapy. There's a lot of impairment, but they come at the beginning of the day, like kind of a work schedule, like 9 a.m. they go through a whole day of group therapy and individual therapy and have a whole team working with them. And then they leave at the end of the day and come back, and they come every day. And so I was a counselor in this program, and it was an amazing opportunity. The requirement for the job was 2 years of college, or I think, and the experience I gained in that job, like hands down, was probably the best training, I had, maybe to date, really, just in terms of what I was exposed to, how that informed me going into my training. And I was able to lead groups. I certainly was trained and observed other psychologists and counselors lead groups, but I was leading groups myself by midway or by the end of my time there, and I just learned so much. So the patients who came through this program were there for a number of different reasons. So depression, anxiety disorders, personality disorders, psychosis or psychotic disorders. So I got this incredibly just like vast exposure to different types of psychiatric diagnoses and presentations and what it really looks like. And also exposure to the evidence-based treatments for how to treat all of these disorders before I went to any kind of graduate school training in psychology.
But that's often the experiences that my students have, is that are already working in human services, doing very meaningful jobs with hands-on people, and now they come back to Hudson Valley to get education to support that. But it's very often my lectures, you are already doing this,
Yeah.
Now you're learning the language that goes along with that. So that's kind of cool to hear you say. So when does the next round of applying to graduate school, and then what kept you from being discouraged? If you 1 for 20, that you're batting 0-50 at the plate, if that's the batting average, right?
I don't know. I mean, I think I knew I really wanted to do this. I think I have a thick skin. I mean, maybe it's, I'll say maybe it's I played soccer all my life, and, I've had some experience with you don't get to play and you have to keep working hard and you're not always going to be the star or whatever. So maybe that helped a little bit. But, I think I just knew I really wanted to do it. I think, maybe it was having, made this big leap. It felt big to me at the time. So, I wasn't about to give it up after feeling like I had given up something else. And yeah, I think I applied pretty soon into this new job again. I had, I think, started in April or May, and applications were probably due the following November, December. And so I probably had 5-6 months under my belt, and had 2 different letters of recommendation as a result of that. I continued some extra research work at McLean that I would do at night. So I would stay after and 2 nights a week volunteer to do more research in a lab. And then I think I probably improved my GRE scores too. So I think it was all three of those things that helped. And then I applied to probably around the same amount of schools, and I got 8 interviews and got in 4 places. So
Wow.
it just shows you that, sometimes it could just be, that round, you don't know. And I applied to different schools, but I applied to the same school that gave me the interview, and they gave me the interview again, but I chose not to go there.
Good for
So,
you. Good for
yeah.
you.
Yeah.
So you go on to University of Vermont. So how long from the time you decided this was your goal
Mhm.
until you became a psychologist, how many years are we talking about? Depending
Until,
on where you start the clock and everything. But if
yeah,
you
yeah.
look at this was the day you said, I want to be a psychologist, and you took steps towards it to, to getting licensed. How many years?
Until I was actually a licensed
Yes.
psychologist.
Yeah.
Okay. That was probably 12 years.
12 years. Okay. A little bit of an investment there then. A little
Yeah.
bit of a time invest, not for the faint of heart. Tell me about graduate school at the University of Vermont,
Yep.
the level of work, your field of study, and whether was that cool or was that a drag or both, or what was going on there?
Yeah, yeah. I mean, I loved graduate school. I felt like it was one of the best times. It was a lot of work. But yeah, I was with some great classmates who were a great support. And it's sort of coursework heavy in the beginning. Um, I think the experience, like your students, like already being, on the ground, working, hands-on, having had that experience made it actually easier. Like I kind of had a leg up going into graduate school in terms of already being comfortable with clinical work, knowing kind of what I was reading about, like when I read about what bipolar disorder is, what generalized anxiety disorder is, what OCD is. I had seen these things, I knew what they were. So I felt maybe a confidence too that was helpful. And with graduate school, you apply to work with a mentor, so you don't kind of just apply to the school and you're enrolled with a large class. There's only, in clinical psychology programs, 3 to 7 people in a class.
Okay.
So it's pretty competitive. It's hard to get into, and it's a small class, and you specifically are applying to work with a mentor, who's going to be your mentor potentially throughout your graduate school career and kind of guide you through the research portion of things and write your, dissertation and theses. So that's sort of one part. Then there's the coursework, that you have to fulfill. And then there's the clinical work.
Mhm.
And so all of
What
those
did you
things.
focus? What was your clinical emphasis in graduate school? What was your mentor like, and what did you dive into?
Yeah, so it's interesting because, again, kind of following what I do, which is I'm not always doing exactly what I ultimately will do. What I do now is I specialize in OCD.
Right.
But my mentor was someone who studied pediatric bipolar disorder.
Okay.
And, part of what I learned when I was applying the first round, I applied to graduate programs and said I wanted to work with anxiety disorders and adults. And I also applied to programs with kids and pediatric bipolar disorder. And I think what I learned was that, given my experience, I'm going to be a better candidate to get into programs where I end up working with someone who is studying pediatric bipolar disorder.
Mhm.
And so that's what I ultimately did. And I was interested enough in it, but I just kept finding I was more drawn to, I would say, kind of like anxiety and depression over bipolar disorder, or just kind of more child disorders in general. But I would say less the sort of externalizing disorders like ADHD or oppositional defiant disorder. These are different disorders in kids. And so I started there, and I was doing my research in emotion dysregulation and pediatric bipolar disorder. And, I wasn't super jazzed about it. It felt a little bit more like kind of a means to an end. I had to kind of get through this. And what I did do though, as I became more apparent, I was just interested in, through my coursework and clinical experience treating anxiety and OCD, I sought out opportunities to do that more in my clinical work. And I sought out opportunities of how can I kind of maybe carve out a research question that might lend itself more to anxiety than bipolar disorder. So one of the things I did in my clinical work is with one of my classmates, we started a tic and Tourette syndrome specialty service at our clinic. And we had someone who's an expert in the field come to the University of Vermont and provide a training for our program. And we created a specialty service. So, we kind of created our own coursework, an independent course that we were training ourselves in evidence-based treatment for tics and Tourette syndrome and obsessive compulsive spectrum disorders. So that was kind of a neat part of graduate school for me.
Meg, hang on. Do folks know what Tourette's is? Yeah. Tics and Tourette's. Okay. All right. Is that connected with bipolar, or is that connected with OCD, or is that's its own thing?
It's its own thing, but I think it is more commonly co-occurring with obsessive compulsive disorder. Okay. So yeah, we saw that there was definitely a need for that. And with my interest in OCD, we kind of like included that in the specialty service as well.
Okay. Yeah. So then as you graduate, and I don't know if I'm hitting fast forward too fast here, but then I know you worked in OCD, and you worked in an OCD kind of inpatient setting. Mm-hmm. Is that right? Tell me about that. Tell me what that's like. And, you and I have kind of talked about that. Well, people say, oh, I got OCD. I have to put all my shoes in order. And people think, oh, heck, all your books are lined up. And then there's debilitating OCD. That's nothing to laugh at. So
right.
Talk about it a little bit.
Oh, sure. Yeah. So after grad school, we have to do an internship first to kind of like, it's almost like a residency in medical school, or like a clinical internship is the last part of what you have to fulfill in grad school. And I actually did that at a different hospital in kids with OCD. So I did that, and I really liked my training there. And then I did my postdoctoral fellowship at McLean, and that's where I worked at a residential program. So this was a program for adults with what's called severe and treatment refractory OCD, meaning they've tried treatment, and hopefully in order to get in the program, this is usually what we require, is that they've actually tried a course of cognitive behavioral therapy with what's called exposure and response prevention. So the evidence-based treatment for OCD, and it hasn't been helpful. Like, that's how they get to our program. And there has to be just a significant level of impairment in their functioning. These are folks who their distress is just extremely high, and they're not working, or it's impacting their ability to parent, function at work, maintain social relationships.
Hey, Meg, can you give us a little Reader's Digest version of the exposure and prevent? What's that treatment like? The exposure to and the response interruption. What's that?
Yeah. So it might be helpful first to just to remind you, if you already know what OCD is. So obsessive compulsive disorder is made up of two things. Obsessions are intrusive, unwanted thoughts that pop into someone's head against their will. They elicit an immense amount of distress, and that distress, which is often anxiety, but can be other emotions like guilt or disgust, then drives a person to engage in compulsions. So they engage in a behavior to take away that anxiety or to undo a thought. So a really common example, right, that we probably all hear about might be, contamination fears. Like, if I touch that doorknob, I'm going to get COVID and I could die. And that brings on a lot of a lot of anxiety, and the person might then wash their hands, but they don't stop at just washing their hands for 20 seconds, like the CDC guidelines, but they might wash their hands for 20 minutes and wash up to their elbows, or they might wash 20 times. So that's just one example. I can talk more about this after too, but there's lots of different types of symptom themes in OCD that aren't what you'd hear about in the movies. And I think that's also why it can be misunderstood too.
Sure.
Exposure and response prevention, what it does is it's two parts. Exposure therapy, kind of is facing your fears in a way. So what you do is you identify the things that trigger your anxiety, like touching public spaces, doorknobs in this example. And you expose yourself to those things, right? So you would practice touching a doorknob, or you might gradually work up to doing things that are the hardest, right? And then what you do is you simultaneously resist the compulsion, and that's the response prevention. So you prevent the response that you want to engage in to take away the anxiety temporarily, right?
You don't wash your hands.
You don't wash your hands. So you do the act, right, that brings on the anxiety intentionally and planfully. And you often come up with what's called an exposure hierarchy. So you kind of come up with like, what would be something that would be like a 3 out of 10? 10's the most anxious you've ever been. What could you touch that would be a 3 or a 4 or a 5? And you come up with things that are all along that hierarchy. And historically, you would work gradually, and this can be a really appropriate way to continue to work to this day, because people build confidence. They're not ready to do a 10 out of 10. That might scare them away from the treatment. So you work up the hierarchy. There's also evidence now that actually kind of treating it more like a menu rather than something you have to go from easiest to hardest. And this is because, you don't want to reinforce that there are things to be more afraid of and things to be less afraid of. Like they're all things that are things you can confront. It's also just more like real life. Like things don't come at us like a 2 and a 3 and a 4 and a 5. And so to kind of mix it up actually can help with the new learning that happens during exposure and response prevention. And that's what's thought to happen, that there's, an association that's made in the brain between the thing that makes you feel scared and fear and needing to do the behavior. And what you're doing in exposure is you're relearning. You're not unlearning. You're learning a new way that you can approach these things, that you can feel anxious, but you don't have to engage in the compulsion. And when you don't, you learn your anxiety comes down on its own without you needing to ask for reassurance or check or wash.
Well, but how about this though, Meg? So suppose that's my fear, and I go touch the doorknob, and now Tom, you're not gonna wash. Don't I freak out? Go, no, I gotta wash. No. And how do you work with somebody? Do you process that? Like, oh Jesus, I gotta, come on, Meg, you gotta let me wash. What's going, is that what goes on? And that must get crazy, right? Or not crazy, but that must get hairy, right?
Yeah, I mean, that does happen sometimes. I mean, I think that's part of why you want to try to create the gradual hierarchy and ask, like, what are you willing to do? So we talk a lot about willingness in the treatment and how that matters. It's helpful if they are willing to experience the anxiety that they're about to experience. How willing are you to have the intrusive thoughts that are going to pop into your head?
Okay.
I think, where the treatment is going is often a blend between kind of ACT principles and exposure and response prevention. So I don't know if you've talked at all about like acceptance and diffusion, but that can kind of give someone some ideas of sort of what to do with all their anxiety and their thoughts during exposure. So some of it is
it's not fun. It's not easy.
It's not fun. It's not easy. I think it's letting people know it's not supposed to be like this is what's supposed to happen during the exposure. There's also a lot of research on, therapist behaviors in exposure and response prevention, how their own anxiety or their own fears that they're harming the patient can get in the way of actually doing the treatment. So if you have a patient saying like, I don't want to do it, I don't want to do it, I could get sick, this is horrible, this is the worst thing ever, a therapist might think like, oh gosh, yeah, it's the worst thing ever, okay, don't wash, right? And so and that can happen as the therapist, like you might not be anxious about the doorknob, or you might actually, right? Like, and so you as the therapist have to work on how are you going to manage the feelings that come up for you around the patient's distress and stay.
And what is the appropriate behavior from a therapist while that's going on? I mean certainly it can't be indifference, like, come on, no big deal, or deal with it. I mean, is it encouragement? Come on, stick with this,
Yeah.
or
Yeah. I think it is that. I think it's encouragement. I think it's stick with it. I think you want to try to remain neutral and calm. I think you can validate the emotional experience. I always think that's something you can always do. Like, yeah, this looks like it's pretty difficult for you right now. You can do it, and you want to stay away from providing any reassurance, like you're probably not going to get sick, it's okay, don't worry. Like if that's why if that's why they choose to not wash their hands, that's not what you want to do in an exposure. You want them to just feel the feelings, have the thoughts, do nothing to take that away, and have them learn that A, their anxiety comes down on its own, or B, even if it doesn't, they can tolerate it.
wow, I like that. Now it's interesting because we've been working with Carl Rogers, and I can't see Carl working with an OCD person and just saying, looks like you're feeling pretty messed up. So what is the style like when you're processing that? What does that sound like? What does that look like? And am I wrong? Are you probably still using active listening techniques and reflecting and summarizing and stuff like that? But what does that look like, or what does that approach like?
Yeah. Well, it's interesting because I myself really like cognitive therapy and Carl Rogers and Aaron Beck, and when I really started digging into OCD treatment, thought, how do you use cognitive restructuring without it being kind of reassurance for folks with OCD? Like if they're supposed to just let those thoughts be there, and I'm not supposed to tell them to come up with evidence for why these things aren't going to happen, like, how do I reconcile this wonderful tool I learned that I rely on
Right.
what I'm learning? And so I think it's a couple things. I don't think it's that you can't use that. I think you don't want to do it during exposure, right? So sometimes it's sort of outside of the moment, when someone's not in a super heightened state. You can practice some of the cognitive work, and that can be, talking about a triggering event, having them complete a thought record. If you've gone over that, like what's the situation that triggered you? What are your automatic thoughts that came up? And with OCD, one of the subtle distinctions, which can get a little confusing, is you want to challenge the distortion, sort of the faulty thinking, not the thought itself. So an example of that, I'm trying to think of an example of that might be, one thing that happens in OCD is that people might think, because I had the thought, I think I'm more likely to act on it. So one type of intrusive thought in OCD are harm thoughts. I don't know if you've heard of that, right? So sometimes obsessions can actually be about harming someone. These thoughts could be like, I think I just had a thought that I'm going to stab my spouse. And that thought really scared me that I had that. And by definition, obsessions are what's called ego dystonic. So that's a fancy word for basically not being aligned with your values, right? And so someone might think, well, because I had that thought, it means I want to do it. Or because I had that thought, it's just as bad as actually acting on it. That's like a horrible thought to have. I'm a terrible person. And so one approach might be like, let's list all the reasons why you're not going to do that, right? Like, let's list all the evidence. Have you ever hurt anyone before? Do you love your spouse? Like all that stuff, right? And there might be some utility to that, but often what happens in OCD is that the person just keeps coming back to, yeah, but what if? But what if? I haven't before, but what if I do it in the future? And so targeting the distortion is really getting at, well, are you thinking that because you're thinking it, you're going to act on it? And being able to challenge that, like thoughts don't cause actions. Okay.
Okay. Yeah.
Thinking something is different than acting on it. Right. And you can challenge that while also trying to actually build tolerance to uncertainty about the thought itself.
So let's talk about when you worked in the inpatient place, how bad, give us an idea how bad OCD can get. Like what, I mean, it's not just, even the idea of the touching the doorknob, that sounds like a really uncomfortable way to live your life. I remember having a guy in my addiction clinic who had OCD, and he was drinking a bottle of bourbon a day. And I was asking him what his OCD was, and he said, well, see the corner of that metal file cabinet? I keep picturing that slamming through your head. And in order to prevent that, I have to do this 5 times. And I said, that doesn't make any sense. He goes, of course it doesn't make any sense, but that's what I do, and it stops it. I said, what if I stopped you from doing that? Well, then I got a secret one that I do back here. And I thought, I'd drink at least a bottle of bourbon if that was going through my head all the time. And that sounds like not even as serious as the folks you're talking about. So how bad can it get?
Yeah, I mean, I'd say it's as severe as it can get in terms of the patients that I saw. I think it's sort of regardless of the symptom theme, it can be about anything and it can get really severe. I mean, it's just in terms, patients can have trouble walking, because they need to do rituals with, the way that they walk or stepping, in between doorways, or, they might be housebound generally because they're not willing to leave the confines of their very clean, safe home environment. I think it can be really so severe that, people are having suicidal ideation in terms of, I don't want to live this way because of the thoughts that I'm having. So, I think it's so severe that they're unable to work. They're usually unable to really kind of be a participant in their family in some way. And there's a range, I'd say that there are some folks who it feels like it's really impacting their ability to just kind of have a normative life, and other folks who, often in the summer in this program, we'd get a lot of more college kids who would come because they would be home from college and could do a really good piece of work over the summer and do 8 weeks of residential treatment. And so they might be individuals who are trying to return to college after that, versus individuals who are really trying to work back up to, applying to jobs or volunteering as a first step to re-enter any kind of workforce.
What are some of the OCD things that we wouldn't picture as OCD things? I mean, we always think of hand washing, we think of rituals, but what things might be OCD that the average person wouldn't see that as OCD?
Yeah. Well, I mentioned the harm thoughts. I think sometimes people don't know about those thoughts or misunderstand them as actually being dangerous if they hear about someone having those thoughts. So harm thoughts can be about the person themselves fearing that they're going to harm somebody else, or just harm happening. Kind of harm by neglect. So that would be like, I see a toy on the floor, and if I don't pick it up, I think someone could trip on it and I'll be responsible if I didn't pick it up. Or there's water spilled on the floor and I didn't wipe it up. There can be what's called relationship OCD. So people who can really kind of doubt if they're with the right person or not. And this could be about a sort of something specific to the person, like a physical feature that they keep perseverating on. Like, I'm not sure if I'm attracted enough to that person, and they obsess about it, and might engage in rituals. They might ask for reassurance from friends or family. Do you think that we're a good fit? Do you think that, what do you think? Should I be with this person?
So Megan, it sounds like a lot of these things are thoughts that we all have at some level, and then OCD takes it over the top. And
absolutely.
Okay.
Yeah, I think that's a great point. I mean, one thing that's important to know about OCD is everyone has intrusive thoughts. They don't just occur in people with OCD. There have been studies that have looked at people without OCD and asked them, like, tell me what your intrusive thoughts are. And then people with OCD, tell me what your intrusive thoughts are. And then, these thoughts given to a third group of people to try to identify, like, who are the people with OCD, who are the people without. And you can't identify the folks with OCD and those without. It's more it's a disorder of degree, like substance use, right? So people drink, but it's how much is that? How much are you drinking, and how interfering is it in your life?
Okay. That makes good sense.
Yeah.
In your private practice, are you working just with OCD patients, or what's your private practice like?
Yeah, I'm working mostly with patients with OCD. I've broadened it to working with perinatal OCD. So I work with mainly women, but I'm open to working with any parent or potential parent. And so perinatal is the period between like pregnancy and up to 2 years after giving birth. And I, since becoming a mom, had more interest in treating parents and as they navigate this time in their life, and also wanted to use my knowledge about OCD within this time. So there's what's called postpartum OCD that onsets after giving birth or during pregnancy, and I've started to incorporate that into my private practice. And so I see mostly patients who have a diagnosis of OCD or postpartum OCD. Yeah.
So how come you don't work in just somebody with run-of-the-mill anxiety or depression or sadness, like, hey, it's Tuesday at 2:00, I need something less intense? How about somebody just has regular neurotic, like your uncle or something like that?
Well, I definitely have patients with anxiety, generalized anxiety disorder, which is actually like, honestly not all that different and than OCD and how you treat it. I mean, there's a lot of overlap, and sometimes it can be pretty similar, just about worries and how people respond to worry. I think maybe it's because I know OCD so well, I actually don't find it as intense as treating depression. Like, I find that harder. I think why I'm drawn to it is people get better with the treatment, and that's really fulfilling. I think it's hard. I think I appreciate and respect people who treat depression and major depressive disorder. I think it's hard. I think that sometimes the sort of lack of motivation or just feeling really down and sad, and that's harder for me, I think, as a clinician to work with. And so I definitely have patients who have depression as well. But yeah, I think for me personally, like, I find it more rewarding for myself, and I feel more comfortable treating OCD.
That makes good sense. What would I hope this question makes sense. What would a session with you sound like? What kind of questions would you ask? What would you? How directive are you? Do you do a lot of Carl Rogers and or do you interrupt and you do it in the CBT or cognitive stuff? What might a session sound like? Or
at the beginning, it's more psychoeducation, more didactic, right? Like teaching things. So setting the foundation for cognitive behavioral therapy. It feels more like a class that I'm teaching, right? Which is why I like cognitive behavioral therapy. I like to be pretty structured and directive, some. And then I think that decreases over the course of treatment with somebody. So, at first it might be, providing education about the relation between thoughts, feelings, and behaviors, asking the patient, like, how would you define a behavior? How would you define feelings? How would you define thoughts? Seeing what they say, providing, my input on their definitions. And then, giving them the knowledge of different skills, specifically, cognitive restructuring and how to do that effectively for OCD. What are pitfalls of it, but then, asking them what was a triggering situation this week where you noticed a shift in your mood, where you went from feeling neutral to anxious or anxious to more anxious, and then them providing, oh, there was this time, this thing happened. Okay. And what was going through your mind at that time?
But there's a lot of structure to what you do. There's a formula. And within that is the art and science of building rapport and such. But you're instructing and you're getting them to develop some self-awareness through this structure. It's not just, well, what I'm hearing you say and doing that a million times. It's okay. One last question, then I'll ask the class for questions. If you have questions. How do you turn it off? So you got, I don't know how many hours a week you're working, but it's a full load, and you got 2 little ones and a very needy husband. Her husband is also a psychologist. How do you turn it off? How do you unwind? And can you turn it off? Or are there weekends where you just sit and drool?
Yeah. Sometimes it's hard. I mean, so what I do is I exercise. I prioritize exercise. I found it a lot harder to turn off when I worked at McLean in the residential program. I found it really hard to hold the kind of suffering that people were experiencing at that level of care. But again, I mean, I think it's self-care, right? So I, make sure I'm trying to get as much sleep as I can. I'm working out, I had my own therapist, to take care of myself. And now, I think changing my job actually helped, like finding what was best for me at that time in my life. So working in a residential program full time, 40 hours plus a week, having 2 kids, and then COVID happening, where I still went into work that never shut down. That program during the height of COVID was a lot. I was pretty burned out. And I think it taught me, I love doing this work, but I don't know if this level of care is the right fit for me right now. And so moving into private practice where I'm doing outpatient level of care, these are patients who need help, but are going to work and are functioning at a high level, most of them. And so I actually do all my work in 3 days. I mean, it's a privilege to be able to do that. Not everyone can do that, but it also gives me time on 2 other days of the week to fit in other things that I, want to get done, like chores in the house, or if my kids are sick, like I can pick them up and I don't need to negotiate who's going to do that now and who's going to find, take the day off or find coverage. That's really helped me like be able to hold more of this. I also have created a peer supervision group of colleagues who we meet once a month to talk about cases to get support. And I just sought out supervision that I pay for from another licensed clinical psychologist, which will be about every other week, to just make sure that I'm getting the kind of support I need around the work that I do.
So that you've really invested in self-care. It's not just, I watch Lifetime TV and I walk around the block. There's some structure and some discipline to that.
Oh, definitely. I mean, there are certainly days where I say, like, do I want to do this? Because it's hard. It's sort of like, I think sometimes it's not always the case, but the things that you do love the most can also bring you, right, the most distress. And so it's figuring out a way to be able to hold that and not just saying, well, I can't do it. You have to figure out a way to manage that. But it doesn't mean that there are times where it feels like, ooh, this is a lot of responsibility, or this feels heavy. And you have to kind of practice what you preach, right? Like, how do I make space for this? How do I diffuse from it? How do I still do what's most important to me, even though I'm feeling this way right now?
I would guess if you got to a point where there wasn't a concern about being able to deal with it, that might be a bad sign.
Right.
Like, this isn't. Oh well, if it wasn't bothering you or something like
Right.
that,
Yeah,
might
you
not
might.
be the best sign of something. Yeah.
Totally. Yeah, right. Like, you want to be, the awareness of it is both what makes it difficult, but also allows you to manage it properly.
Interesting. Let's see if there's questions. Christina,
No,
go ahead.
I have a couple.
Okay. All right.
Okay.
Erica.
I love that idea about the support, the group support, like with other people who are your peers in work. It seems it's so cool. And maybe something I remember someday. I even write it down because I'm like, I'm going to try to do that when I get into counseling. Because it's a great, because people, when you're at work or even if you're working from home, especially at the pandemic, you're not really getting to be creative, bouncing ideas or just, are you doing this right? What do you think about this person? Or, like I was fascinated about this subject or this career, but to the point where I couldn't wait. Like, I wanted to talk to my teachers when I first got here, like as my peers, like, can we talk about sick or can we talk? I just wanted to kind of have a conversation about all the topics that revolve around recovery. And I can see that I'm in an internship right now, and I can see Fran doing that. We talk all the time, and I can see that it's helpful to him to talk to me, like talking about issues.
Erica's internship is in a pretty hardcore detox.
Okay.
Acute care detox, so they're monitoring vitals, and people are in hospital gowns, and it's not a lot of counseling, but I really like it. It's really good for me. The counselor is the class within not the counselor. Yeah, Fran, my supervisor, we sit in an office for a long period of time, so we talk about things, and he lets me say, hey, if I said I really wanted to say that in that room, because I'm not allowed to say anything with patients, and he's like, he just says it, it teaches me. He teaches me what he thinks. And he says, I don't know if that's, you don't have to take my advice on that, but here's what. And then, weeks later, he said, I can see you getting better at this. You're talking more clinically then, and you're seeing through, like, instead of saying, oh, that's great that your kidney's failing and you want to, this is different for you this time. And like being like rah rah instead of, okay, that's really good, but this is like the fifth time I've seen people's esophagus basically falling out and they still drink. What's your plan? What do you have to plan? And that's just so anyway, I love that you do that. That support is really important because people you need to talk to your peers about it. Sometimes that work relationship's not available.
What's that group like when you meet? I'm sorry.
No, it's okay.
When you meet with the peers, what is that? I'm guessing that's not just Chardonnay and fine cheese and those crazy people this week. What's it like?
I know. We try to keep it a little bit structured, where at the beginning we might say, does anyone have any cases that they really want to talk about or any questions that they want to talk about, and kind of just hear from everybody around. It's 3 people, so it's not so many people that want to share. And then, there might be someone who says I have a case I want to talk about, and another who says I don't really have anything major. I could ask a question, and we just sort of prioritize the meeting based on that. And then we might even set a general time guide for everyone. Why don't we try to spend 20 minutes on each of these? And then if we have time for the questions at the end, we'll do that.
Okay. So it's the real deal. It's not anything frivolous. It's not night out with the girls or the guys or anything like that. It's a real thing.
Yeah, it's a real thing.
It's formal. That's even cool.
Yeah.
I just wanted to ask one more question about
Sure.
the pandemic. Has that OCD sounds like something that's not really a cause and effect, kind of like you didn't have trauma maybe to cause the OCD. It just kind of happened in your brain more so than any other depression or anxiety or suicidal ideation kind of things. But do you find that that you got like that the pandemic caused a lot of more cases and you're busy and you got like weird different types of things that are like, kind of popping up that you don't even know what to make of them and you don't have a textbook rule for them?
Could you hear that? He's asking about pandemic and OCD.
Yeah, I think it's a great question. I think it impacted OCD in a number of ways. I think that, so one is, I think, so OCD is kind of this combination of genetics and environment, right? So you're kind of more likely to have it if a family member had it, but can certainly be impacted by your environment and what you learn. I think with COVID specifically, a lot of people started asking like, oh my gosh, treating OCD during the pandemic, like what was that like for people with contamination fears, right? So I think it didn't sort of create more OCD necessarily, but it could have been pretty triggering for those who had contamination fears. And it was more of a time where we really needed to focus less on the exposure. Like, we're actually not going to have you touch a doorknob now, like, but we're going to focus on the response prevention. So you do what the guidelines say and do no more. Right.
Gotcha.
And so that was what was kind of hard. And when someone has OCD, they always want to do more. So even though they were washing, it wasn't like, oh, now they're getting away with their rituals. It was usually like, that's not going to feel like it's enough. So it was interesting working in a residential program where we're having people like touch doorknobs and eat without washing their hands, to now we're asking people to wear masks and to wash their hands. And wait a minute, how do we incorporate this into what we're doing? And so I think it really was an adjustment to say, we have to be flexible. Like, this is part of what you learn in OCD treatment, is being flexible too, that right now, like, it has changed. Actually, these are the guidelines now and we need to follow them, but we don't want to do more. And your OCD is probably going to want to do more. The other way it impacted people was more just like, how much the pandemic affected everybody with being isolated and the stress of it. And I think really kind of that isolation, right, of like what it cost a lot of people and what it was like for people with OCD to not be able to go out and spend time with their loved ones or to connect with people. So I think you may actually just see more mental health problems as a result of COVID. And so with that, you're also seeing an uptick in OCD, but probably no different than you might be seeing it in other disorders. Yeah.
Christina had a question.
First off, thank you for speaking and taking the time. So earlier you were talking about oppositional defiance therapy. Now, and as far as OCD goes as well, have you worked with children? Because I'm on the fence right now between psychology and social work. I'm not quite sure which way I want to go. I just know I want to work with children. So I'm wondering, have you worked with children that have struggled with OCD, and what does that look like?
Yeah, sure. Yeah, actually, my training is mainly with children. So I was in a child lab in graduate school, and then all of my clinical training prior to postdoc was OCD across the lifespan. And in fact, my internship was exclusively with children, and I worked in an OCD partial program, at an outpatient program. I worked in a adolescent inpatient unit. I worked in a therapeutic day school for my training, and I worked in pediatric psychology. So, folks with medical illnesses who were also seeing a psychologist. So I worked across the lifespan. I always loved treating OCD kind of regardless of kids or adults, but I have moved more towards adults. I find I like that work more. OCD in kids, a lot of it is pretty similar in the manifestation in terms of the kind of thoughts you can have and the compulsions you have. So you see really similar themes come up: contamination. You can see harm thoughts come up. That might tend to happen a little bit later, like when kids are a little bit older, to have more of those harm thoughts. You could have the sort of symmetry and ordering. And with kids, one thing that's important is to know what's developmentally appropriate right? So there are certain times, in child development where actually being very organized and wanting your things in a certain way and putting things in a certain way, right, is actually developmentally appropriate. So that's a piece that's interesting in child work, is really actually, it's important, I would say even more important, to understand developmental psychology and normative developmental psychology so that you can understand what is not normative. So that's one part that I would say is maybe unique. Sometimes kids, you're going to see the compulsions more, and you're going to have more access to the compulsions because kids don't have as much insight into the thoughts that they're having. So they're not able to articulate. A 5-year-old isn't able to articulate, I'm having like a harm thought, right? Or that thing doesn't look right. They might be able to just say like, it's supposed to be this way, or you might just see them ordering things a certain way. You might see them wash their hands a lot, but they're not able to really say as articulately, I'm afraid I'm going to get ill because of germs. Now, I don't want to discredit kids. A lot of kids can, but that's one thing in my training I learned as well, is that you might find that the compulsions are really apparent. They're not able to identify the thoughts. It doesn't mean they don't have OCD. And that's why incorporating parents. So that's the last thing I'll say, is the family work in child OCD and probably in child, psychotherapy in general is going to be really important. So you're often, if you'd become a child therapist, you're probably working with the parents as much as you are with the kids, at least up until adolescence. And so with OCD, it's a lot of, talking to the parents about how they might be actually engaging in rituals or accommodating the OCD and not recognizing it. So if their child is saying, mommy, can you please stay in the room, you can't leave, I think something bad's going to happen, and you keep staying and you keep staying. And this isn't a kid who you say everything's going to be okay and then they're okay. This is a kid who just has to keep asking, and you have to keep telling them. It might be imparting the knowledge on the parents that this is what's called reassurance, and actually to help your child, the best thing you can do is you actually have to resist giving that reassurance. And that can be really hard for parents, and figuring out when to do that.
I actually, my son was scared of beeps because we went at a lake house and we watched their house. They had an alarm that went across the lake practically. He was just little, so he was always afraid like the beep beep. And I literally promised, like he was like looking around. It was probably 7 by that time at a hotel. We had to be up for a wedding. In the wedding, he's looking around and sees all the fire alarms, and he calls them beep beeps. And I said, I promise you, they are not going to go off. That is just for safety. It's a hotel. They have them there. It's not going to happen. No way. And I learned my lesson that time. Just in 35 years, the hotel was up 4:30 in the morning. Those things went off. And I was like, I can't believe that. What are the chances of that happening when? And he was freaked. We had to go out and sleep in the car with him. And well, we were on our way to leaving anyway. But it was the next day, thank God. But it was so that taught me, and somewhat, I didn't know how to phrase it or how to connect it. That taught me that it's okay not to tell them that it might not be all right. We might get a really big thunderstorm, and what do you and ask them, what do you think's going to happen? What is that you're most afraid of? And I can tell them, well, that's definitely not. I don't say that's definitely not going to happen. I say that those are things that could happen, but the odds of that, or something, or just cool.
Like the rest of us.
Very fascinating.
I don't want to keep Meg too much longer. Other questions? You said you had a couple. So.
Yeah. So as far as tics go, is that something that would fall into OCD as well, or is that something that's separate?
It's separate. Yeah, it's its own tic disorders, or its own classification of disorders. And there's been some work at really trying to distinguish the two. Are there overlaps, or kind of a tic-like OCD? But they're separate. So tics are involuntary movements, like a movement disorder, or you can have a vocal tic. And so the treatment with tics is more around kind of identifying the feeling that you get before you tic, and then coming up with more helpful responses. So the idea with tics is that they're involuntary, but they can be voluntarily suppressed, which is sort of a tricky idea. And when you're distinguishing it from OCD, one of the distinctions can be to try to identify, is there any thought that is coming before the repetitive behavior? Is there any kind of obsession or cognition? And often there isn't. It's more of a physical feeling they get. Like if you were to open your eyes right now and not blink and continue not to blink past the feeling, right? Past the point where you want to blink. If you're doing it, you're like, oh my gosh, I want to blink. That's what it feels like for someone who probably times 100 who feels like they need to tic. And that's what it feels like when they feel like they need to move their shoulder up or they have to say something. And so that it's more of a feeling rather than like, I'm afraid something bad's going to happen. And so now I need to blink my eyes 3 times. Now, if we found that out, then that would be really helpful to uncover like what's what and how do we treat that.
Just to kind of self-disclose just a little bit. So I have a son, I adopted him when I was a baby, who has, he started tics at a young age.
Yeah.
Pediatrician said it's something that he would probably grow out of by 13. But I've noticed that he started doing hand flapping and handshaking and stuff like that, which is becoming more noticeable. And I mean, he's almost 13 now. So I was told, to make him aware of it, stop flapping your hands, relax. But obviously it's something they can't control. So would that be something that you tell them to acknowledge it, or are you harming them by saying, don't do this, because they can't control it?
Yeah, it's a great question. There's generally 3 parts to the treatment. So one is awareness training. So the first thing you would want to do is try to cultivate awareness in the child or adult with tic disorder. So, make them aware of the urge to tic before, and in treatment with a provider, the way that might look like with a kid is you play a game. Like, I want you to raise your finger every time you feel like you want to tic. I'm going to raise my finger if I see you tic. Okay. But I want you to try to get the most sort of points. And so that starts to just get them paying attention to what it feels like and catching it, right? The idea is they're catching it before they tic. You can say it's okay if you end up ticking, that's no problem, but I want you to raise your finger when you feel like you want to tic. So that's one. You try to cultivate awareness. 2 is you develop what's called a competing response. And this is all called, by the way, habit reversal training. A competing response has to be physically incompatible with the tic. So if you're doing the competing response, you can't also be ticking. Okay. You want to be able to do it anywhere, and you don't want it to be more noticeable than the tic itself. So you want it to be subtle, right? Because part of the reasons why tics are impairing are that it brings on negative social attention. That's a pretty big driver of why people want to change. So, if someone was, moving their arm as their tic, and you would sort of slow down the process and really want to try to find like, what's the first movement of their arm shoulder tic? The first movement is that their shoulder comes up. And so the competing response, you want to kind of directly target that and say, okay, when you have the urge, you're going to push your shoulder down and press your arm subtly into your body. So if you're doing that, if you're pushing your shoulder down and touching, towards your body, you can't simultaneously be moving up. And then last but not least, and this kind of answers your question, Christina, is that family support, social support. So how do parents engage with seeing the tic? And so one thing is the recommendation is not to say stop ticking, but rather, to encourage them to use their competing response. And so sometimes with kids, right, they're like, oh, come on, mom, like, don't want to do it, or like, so you also want to come up with, how are they going to receive that best? How can they receive your feedback and actually implement it without getting annoyed? So sometimes that might be like, talking about like, this is to help you, I'm on your team, and like, maybe it'll be subtle. Like, I'm going to give you a thumbs up, or like when I raise my finger, it means like, oh, I'm just noticing you could use your competing response right now, so just a little more subtle. But yeah, the emphasis is much more on what they can do to help versus like saying you're doing this thing wrong, or, not that you're saying that, but don't do it, is more of that kind of negative attention that you want to take away.
Thank you so much.
Yeah.
You've been quite generous with your time. I really appreciate it. Probably let you go at this point. I know you got your 2 daughters to take care of.
Well, thank you. This was fun. Anytime.
Thanks so much. Really appreciate it. Everybody,
Hey.
see you. Say hi to everybody, okay?
Okay, I will. Thanks.
Bye-bye.